So next is pulmonary embolism. It's V29. A 75-year-old man develops sudden onset breathlessness 3 days after a laparoscopic right hemicolectomy for colon cancer. His left calf is swollen and tender. Physical examination otherwise unremarkable. His respiratory rate is increased to 25 per minute and his oxygen saturation is dropped to 85%, but has improved to 94% with 2 liters of oxygen. Heart rate is increased to 110 per minute. Blood pressure is stable around 110 over 60. And ECG shows only sinus tachycardia and a chest X-ray is normal. What is pulmonary embolism? A PE is a thrombus, a tumor, fat, air, or foreign matter that is blocked pulmonary artery or one of its branches. What are the risk factors for PE? Based on the varicose triad, hypercoagulable states, endothelial injury, and venous stasis. These three are the basic principles on which we have to see any patient who has the risk factors. What are the ECG changes with the PE? Mostly the ECG is sinus tachycardia, but in 20% of the patient there might be strain of the right heart, tall P waves, and right bundle block or right axial deviation on S1Q3T3 pattern or AF. These findings may suggest AV, but a normal ECG does not exclude PE. How will you determine the likelihood that this patient has had a PE? Although PE is not diagnosed by history or physical examination alone, a scoring system that's called Wells score should be used to determine the pre-test probability of PE before further investigations. So PE Wells score, hemoptysis 1 score, malignancy 1 score, previous PE DVT 1.5 score, post-op 4 weeks from the surgery 1.5 score, history symptoms suggestive of PE 3 scores, PE more likely diagnosis other than diagnosis 3 scores. So total score is 11. So clinical, how to interpret: if someone has a score 0 or 1, probability is less 10%. If someone is scored 2 to 6, probability is 30%. If someone is scored 6, then it's 60%. So 1, 10%, 6 around 60%, 2 to 6 around 30%, and 6 more than 65%. In this scenario, the Wells score is 8.5. So your FY1 suggests requesting a D-dimer. How do you respond? In this the clinical pre-test probability of PE is high, so D-dimer is not measured. In situation, the negative predictive value is low. However, negative high sensitivity D-dimer relatively exclude PE if the pre-test probability of PE is low or moderate, Wells score less than 5. A positive D-dimer would not confirm PE. Non-specific elevation of D-dimer is common in patients with cancer or pregnancy. How will you investigate this patient? So CT, pulmonary angiography, spiral CT, helical spiral CT chest with IV conduct. This is particularly useful as it can identify other causes for the patient symptoms should not have PE. How would you investigate a patient if the renal function tests are impaired or if it is allergic to contrast? Doppler ultrasound scan of the veins of the lower limb may be performed if there is a renal impairment or allergy to contrast. If the presence of a DVT is confirmed, then anticoagulation is required and the respiratory symptoms may be assumed to be due to PE. However, if ultrasound is negative, nuclear medicine, ventilation perfusion scan would be required. How is PE classified anatomically? It could be saddle, it could be unilateral, it could be bilateral, or it could be lobar or segmental or subsegmental branches. Sometimes a clot in the right heart is present and it is called clot in transit. CTPA demonstrates a filling defect in a segmental branch of left pulmonary artery. How you will treat the patient? The filling defect is consistent with the PE. Immediate initiation of the full anticoagulation must be considered, but the risk of recurrent PE and bleeding should be balanced. And usually we start low molecular weight heparin at therapeutic dose, but if you're worried about the bleeding, then we can start IV infusion of unfractionated heparin for 48 hours just to check the bleeding. If patient remains stable in 48 hours, then we can switch to low molecular weight heparin. And initiation of oral anticoagulant may be considered like warfarin or direct oral anticoagulant. However, in the context of malignancy, continuing subcutaneous low molecular heparin is the treatment of choice. Anticoagulation should be continued for at least 3 months. Thank you.